Welcome to the Lecturio podcast. Today we are breaking down the vast and frankly sometimes really overwhelming topic of diabetes mellitus, and we're tailoring this specifically for you, the nursing student listener.
Yeah, the goal here is to really balance a foundational theory with the practical clinical tips that you'll need to become a great nurse.
Right, and we are pulling from a really robust stack of sources today. They cover everything from the physiological differences between the types of diabetes to that massive arsenal of oral and injectable medications and those really serious vascular complications.
And, the intention isn't simply to just memorize a list of drugs or symptoms. The goal is to really grasp the why behind the treatments.
Yeah.
Because when you understand the underlying mechanisms, when you see how the gears are turning or, well, failing to turn, the clinical management becomes so much more intuitive when you're actually out there on the floor.
Okay, let's unpack this. Before we dive into how to treat the disease, I think we need to understand what is physically broken in the body's glucose metabolism.
That's a good place to start.
So our sources define diabetes mellitus as an impairment in how the body produces or utilizes insulin. And this results in chronic hyperglycemia or high blood sugar, which eventually damages multiple organ systems. But not all diabetes is the same.
Right, and that is the fundamental distinction every nurse needs to master early on. Let's look at type 1 diabetes first. It's actually relatively rare, making up only about, 5 to 10% of all diabetes cases.
Wow, just 5 to 10%.
Yeah, it's a small slice. This is an autoimmune condition. Often it's triggered by a viral infection or maybe an environmental toxin, which essentially prompts the body's own immune system to attack and completely destroy the pancreatic beta cells. And those are the specific cells responsible for manufacturing insulin.
I always like to use a factory analogy to picture this. So imagine the human body is a factory that runs exclusively on sugar. The insulin is the key that unlocks the factory doors so the sugar can actually get inside and power the machines.
I like that.
So in type 1 diabetes, the key maker, the beta cells, are completely broken. There are no keys, no entry.
That is a highly accurate mental model. Because there is zero insulin production, the onset of type 1 is usually very abrupt. It often presents during childhood or the teenage years, and the patient's body essentially just goes into a massive energy crisis.
But then we have type 2 diabetes, which is a totally different story. The sources note this makes up the vast majority of cases, like 90 to 95%, and it has a much more gradual onset, typically in adulthood.
Yes, type 2 is driven by a really complex interplay of genetics and environmental factors, most notably obesity and physical inactivity.
Okay.
So, to borrow your factory analogy, type 2 is a factory that's working overtime. The pancreas is still producing the keys, the insulin, but the locks on the factory doors are just jammed.
Ah, so the cells are ignoring the shipments.
Right. The cells of the body are ignoring the insulin. They have developed insulin resistance. Over time, the pancreas tries to compensate by pumping out more and more insulin until it eventually just exhausts itself and production drops.
Now, what does this actually look like when a patient walks into the clinic? Our sources highlight some classic shared symptoms for both types. There's polyuria, which is frequent urination, polydipsia, excessive thirst, polyphagia, excessive hunger, and severe fatigue. But why do these specific symptoms happen?
It's basically a domino effect.
Hmm?
Because the glucose can't get into the cells, it builds up in the blood. The kidneys try to filter out this excess sugar, pulling water right along with it through osmosis.
Oh, so that causes the massive urination, the polyuria.
You got it. And because the patient is losing so much fluid, they become incredibly thirsty. That's the polydipsia. And finally, because their cells are quite literally starved for energy, they feel that extreme hunger and fatigue.
Okay, that makes sense. But I noticed the sources highlight a stark difference in weight presentation between the two types. Type 1 often features sudden, unexpected weight loss, whereas type 2 can be asymptomatic for years. Why is the type 1 patient losing weight if their blood is full of sugar?
Well, because the body is literally starving. In type 1, the complete lack of insulin means absolutely zero glucose enters the cells. So to survive, the body begins rapidly breaking down fat and muscle tissue for alternative energy.
Wow.
Yeah. But in type 2, there is usually just enough insulin present to prevent that catastrophic breakdown, which is why it can remain hidden for so long. A type 2 patient might only come to the clinic complaining of, say, blurry vision or maybe a foot infection that just refuses to heal.
And to officially confirm the diagnosis, we rely on specific lab values. So as a nursing student, you're looking for an HbA1c, which measures the average blood sugar over the past few months of 6.5% or higher.
Right.
or a fasting plasma glucose of 126 milligrams per deciliter or more. There's also the 2-hour plasma glucose test, where a result of 200 or higher confirms it. If they are showing the classic symptoms we just talked about, a random blood draw of 200 or more is enough to make the call.
And this raises a really important question regarding terminology that often traps students during exams. We're discussing diabetes mellitus. As a nurse, you must firmly differentiate this from diabetes insipidus.
Yeah, they do sound almost identical, and they both feature extreme thirst and frequent urination, right?
They do, but the underlying mechanism is entirely different. Diabetes insipidus has nothing to do with blood sugar or insulin or the pancreas. It's an issue where the kidneys simply cannot concentrate urine, usually due to a lack of antidiuretic hormone from the pituitary gland.
Ah, okay.
So when you are on the clinical floor, you have to be careful not to mix up the insulin-related metabolic disorder with the hormone-related kidney disorder.
Good tip. Okay, so we understand the mechanical failures of type 1 and type 2. Now, how do we intervene? Type 1 is straightforward, right? The body makes no insulin, so we must administer insulin. But type 2 has a massive, frankly intimidating arsenal of oral medications. Instead of just reading a list, let's try to organize this physiologically. Let's follow a carbohydrate on its journey through the body and talk about the drugs that act at each checkpoint.
I really like that approach. It transforms a scattered list into a much more logical narrative for the students.
Let's start right at the beginning, the gut. A patient eats a meal, and the carbohydrates enter the digestive tract. Here we can deploy what I like to call the digestion slowers, the alpha-glucosidase inhibitors like acarbose.
Yeah, and these drugs do pretty much what their name implies. They block the enzymes in the small intestine that are responsible for breaking down complex carbohydrates.
So it just slows everything down.
Right. Because the carbs are digested much slower, the glucose enters the bloodstream at a controlled trickle rather than a massive flood.
But the sources list a major nursing tip here. It mentions significant GI distress, specifically borborygmus, which is a very fancy word for loud bowel sounds. Why does slowing down digestion cause so much gas and rumbling?
Well, because those complex carbohydrates that aren't broken down in the small intestine, they just continue moving into the large intestine or the colon. And the bacteria living in our colon absolutely love undigested carbs.
Oh no. So they feast on it.
They do. They begin to ferment them. And that bacterial fermentation produces a huge amount of gas, leading to bloating, flatulence, and those really loud rumbling sounds. A major clinical benefit, though, is that because these drugs don't increase insulin, they carry no risk of causing low blood sugar when they're used alone.
Let's continue the journey. So as food moves through the gut, the intestines release natural hormones called incretins, which tell the pancreas to get ready. And this brings us to the incretin protectors, the DPP-4 inhibitors, like linagliptin.
Incretins are wonderful little hormones. They stimulate insulin release and they suppress glucagon, which is the hormone that raises blood sugar. But the body naturally breaks down these incretins very quickly using an enzyme called DPP-4.
And linagliptin blocks that enzyme.
Right. By protecting the incretins, we prolong their beneficial effects. The crucial nursing tip here, though, is that you need to teach your clients the signs of pancreatitis, like severe abdominal pain radiating to the back. It's a known, albeit rare, complication of these drugs.
Got it. Now the signal reaches the pancreas itself. Here we can use the insulin stimulators, the sulfonylureas like glipizide, and the meglitinides like nadiglanide.
And these medications actively force the pancreas to squeeze out more insulin, regardless of what the blood sugar currently is.
And that leads to a massive clinical teaching point about timing. The sources emphasize that meglitinides, for instance, act incredibly fast. If you hand a patient this pill, they must eat within 30 minutes. If you give a patient a drug that forces insulin into the blood and they don't eat, what happens?
They will crash into severe hypoglycemia. That is a dangerous, potentially life-threatening drop in blood sugar. As a nurse, you really have to verify that their food tray is literally in front of them before administering these fast-acting stimulators.
That is so important.
It is. And additionally, because insulin is a storage hormone, actively pushing more of it into the system often leads to weight gain.
Moving on from the pancreas, let's head over to the liver. Here we find the most famous type 2 medication of all, metformin, which is part of the biguanide class. I call these the liver managers.
Metformin is a brilliant drug. It improves how muscles use glucose, but its primary job is telling the liver to stop producing so much of its own glucose. It is almost always the first line of defense.
Now, I saw a huge red flag in the nursing teachings for metformin. It says you must instruct the client to stop taking it prior to any medical imaging tests that use iodine contrast dye. What is the physiological clash happening there?
It really all comes down to clearance. Contrast dye is very hard on the kidneys. It can temporarily reduce their filtering ability, and metformin is cleared from the body entirely by the kidneys.
Ah, so there's a backup.
Exactly. If a patient gets contrast dye, their kidneys might stall, causing the metformin to build up to toxic levels in the blood. And this can lead to a rare but highly lethal condition called lactic acidosis. So as a nurse, you hold the metformin before the scan,
Yeah.
and you don't restart it until you verify the kidneys are functioning properly again.
Oh, wow. Yeah, that makes a lot of sense. Okay, next stop on the journey, the body's cells. The locks are jammed, remember? So we use insulin sensitizers, the thiazolidinidones like pioglitazone, to sort of grease the locks and decrease that cellular resistance.
Right.
But the sources note two big warnings here: an increased risk of bone fractures and a major risk for patients with heart failure. Why would a blood sugar drug affect the bones and the heart?
It's all about how the drug alters cellular pathways.
Mhm.
In the bones, these drugs can actually push stem cells to develop into fat cells rather than bone-building cells, which gradually reduces bone density, hence the fractures.
That is wild. And the heart.
As for the heart, these medications act on the kidneys to reabsorb sodium and water. This leads to systemic fluid retention. For a healthy heart, extra fluid is manageable. But for a heart failure patient, that extra fluid volume can easily push them into acute decompensation.
Finally, we reach the end of the journey, the kidneys. This brings us to the kidney bouncers, the SGLT2 inhibitors, like canagliflozin.
What's really fascinating here is how modern pharmacology tackles hyperglycemia from almost every conceivable angle. I mean, we've managed the liver, stimulated the pancreas, slowed the gut, and sensitized the cells. Now we are simply throwing the sugar out the back door.
Just getting rid of it entirely.
Yep. SGLT2 inhibitors block the kidneys from reabsorbing glucose back into the blood, forcing the body to just excrete it in the urine.
But pouring sugar into the urinary tract creates its own problems, right? The clinical implications list a high risk for urinary tract infections, genital fungal infections, and polyuria. I'm guessing all that sugar makes a great buffet for bacteria and yeast.
You're spot on. You are creating a warm, incredibly sugar-rich environment. It is the absolute perfect breeding ground for opportunistic infections. So nurses must heavily emphasize perineal hygiene and hydration for patients on these meds.
To round out the oral arsenal, the sources briefly mention dopamine antagonists like bromocriptine. They activate dopamine receptors in the central nervous system, which somehow improves glycemic control, though the exact mechanism is still a bit of a medical mystery.
Yeah, it's a vast list.
Yeah.
But by following that physiological journey, the nursing teachings, from the GI distress of acarbose to the UTI risk of canagliflozin, they all stem logically from the mechanism.
And here's where it gets really interesting. Pills are no longer the only option for type 2. The medical field is rapidly expanding into non-insulin injectable medications. We are talking about incretin mimetics like GLP-1 receptor agonists and amylin mimetics.
Oh, these have truly shifted the paradigm in diabetes care. They are synthetic versions of natural hormones. When a patient injects a GLP-1 agonist, it does several things beautifully. It slows gastric emptying, it tells the pancreas to release insulin only when glucose is actually present in the gut, it suppresses glucagon, and it acts on the brain to significantly increase satiety.
Meaning the patient feels full much faster.
Exactly.
Now, I have to ask a practical pushback question here. If a patient is already terrified of needles, why on earth would we put them on an injectable that isn't even insulin? Why not just exhaust the oral pill options first?
It's a very valid concern from patients. But unlike insulin, which is honestly a bit of a blunt instrument directly replacing a hormone and carrying a high risk of dropping blood sugar too low, these medications are elegantly orchestrating a broader metabolic response.
Okay, how so?
Because they only trigger insulin when food is present, the risk of hypoglycemia is incredibly low. Furthermore, because they slow digestion until the brain is full, they frequently result in substantial weight loss. And that directly attacks the underlying insulin resistance of type 2.
Oh, wow. So they aren't just managing the symptom, they are helping alleviate the root cause by aiding weight loss. The sources also mention amylin mimetics, which can actually be used for both type 1 and type 2 diabetes, usually injected right alongside mealtime insulin.
Correct. But as the nurse educator, you have to be vigilant about the adverse effects. Because they slow the gut down, they often cause severe nausea or GI distress initially. There is a risk of pancreatitis, and some formulations carry a warning for a rare type of thyroid cancer.
That's good to know.
And while they rarely cause low blood sugar on their own, if a patient is taking them in conjunction with insulin, the combined effect can easily trigger hypoglycemia.
Which leads to some really crucial clinical education points. First, if a patient is using immediate-release incretin mimetics, they must take them 60 minutes prior to a meal. If they wait until after they eat, the drug misses the window to orchestrate digestion.
Right.
Second, because these drugs physically slow down gastric emptying, they can severely alter how other oral medications are absorbed. If your patient is relying on oral contraceptives, for instance, the delayed digestion might change the absorption curve of the birth control pill, rendering it less effective.
Yeah.
You really have to flag that.
And a very practical tip for the floor. Teach your clients never to inject these non-insulin medications into the exact same site they use for their daily insulin injections. You want to avoid tissue damage and unpredictable absorption.
Okay, so what does this all mean? We have discussed a massive amount of pharmacology. We've traced the journey from the gut to the kidneys. We've got pills altering stem cells. We've got sophisticated injectables mimicking brain signals. But why are we working so aggressively to manage this?
It's a fair question.
Like, what actually happens to the physical body if the nursing management fails? I mean, sugar is something we eat every single day. Why is it so destructive when it just sits in the bloodstream?
Well, if we connect this to the bigger picture, we have to look at the microscopic inner lining of the blood vessels, the endothelium. When blood sugar remains chronically elevated, the glucose molecules actually begin to chemically bind to proteins in the blood vessel walls.
Wait, they just bind directly to the vessel?
Yeah, and this creates what are literally called advanced glycation end products, or AGs.
Advanced glycation end products. So this is the rust we talked about at the beginning of the deep dive.
Yes, that's the rust. These AGEs trigger a massive cascade of inflammatory factors. It causes profound endothelial dysfunction and oxidative stress. The blood vessels lose their elasticity. They become stiff, narrow, and highly susceptible to plaque buildup. It's essentially a systemic, slow-moving destruction of the body's plumbing.
And that plumbing damage leads to the devastating complications we see in the hospital. Let's look at the microvascular damage first. The really tiny, delicate vessels.
Sure. So in the eyes, the destruction of those tiny retinal vessels leads to retinopathy, which is actually a leading cause of adult blindness. In the kidneys, the high blood sugar forces the organs into a state of hyperfiltration.
Meaning they're working too hard.
Yeah, they're frantically overworking to clear the toxic glucose levels. This extreme pressure blows out the delicate filtering vessels, leading to progressive nephropathy and eventually renal failure.
And then there are the nerves. The sources highlight that the peripheral nervous system takes a massive hit. But why does high blood sugar cause nerve damage?
Because nerves don't survive in a vacuum. They are fed by their own microscopic network of blood vessels called the vas and nervum. When the rust destroys those tiny blood vessels, the nerve literally suffocates and dies.
Oh, that's terrible.
It is. This leads to severe neuropathic pain, burning sensations, and eventually complete numbness, usually starting in the feet.
And for a nurse on the floor, that numbness is a flashing red siren. A patient might step on a thumbtack or get a severe blister from a tight shoe and feel absolutely nothing.
Exactly.
And because the blood flow is also compromised, that undetected injury receives no immune cells to fight off bacteria. It can turn into a raging infection in just a matter of days.
Which bridges us directly to the macrovascular complications, the damage to the large major arteries. In the brain, the stiff, narrowed vessels and decreased blood coagulability dramatically spike the risk of strokes. In the heart, accelerated plaque formation leads to coronary artery disease and massive myocardial infarctions.
And in the extremities, we see peripheral arterial disease. When you combine that large vessel blockage with the nerve numbness and the impaired wound healing we just mentioned, you arrive at the tragic reality of diabetic amputations.
Yeah, and there are broader systemic risks too. That chronically elevated sugar-rich blood creates an ideal buffet for bacterial cells, making simple infections much harder to eradicate. Furthermore, cancer cells thrive on glucose. A continuous high-sugar environment actually provides the metabolic fuel for tumors to proliferate.
It's just total systemic failure if left unchecked. This is why client education is the most powerful tool a nurse has. We have to teach them the why. We have to empower them to manage their diet, monitor their glucose, inspect their feet every single day with a mirror, and adhere strictly to that complex medication journey we mapped out.
And when the balance tips, you must immediately recognize the signs of a diabetic emergency. Whether treating type 1 or type 2, if you observe sudden, intense hunger, cold, clammy skin, profuse sweating, drowsiness, or a weak, rapid pulse, you must act.
Yeah, those are the classic red flags of severe hypoglycemia. It means the blood sugar has dropped dangerously low, very often as an unintended side effect of the very medications we're using to treat the hyperglycemia. It requires an immediate intervention with fast-acting carbohydrates.
Recognizing those signs before the patient loses consciousness is a critical nursing skill.
Okay, let's bring this all together. For you, the nursing student listening right now, mastering diabetes mellitus comes down to a few key pillars. First, understand the mechanical failure. Type 1 is a broken pancreas lacking the beta cells to make the keys, while type 2 is a tired pancreas fighting locked resistant cells.
That's right.
Second, don't just memorize the massive list of medications. Follow the journey. Group them by their mechanism, whether they are slowing the gut, pushing the pancreas, managing the liver, or flushing the kidneys, so the side effects and nursing teachings logically make sense.
And finally, always remember the stakes. Poor glycemic control isn't merely a bad lab value on a chart. It is the physical rusting of the vascular system, leading to blindness, kidney failure, and amputations.
So keep studying, keep breaking down these complex pathways, and keep learning with Lecturio. Your future patients are relying on you to understand the why, so you can be a great, well-prepared nurse.